quite a few interviews.
This big ball that you have the camera, what is that?
It's a virtual reality camera,
So there are two cameras?
it's 6 cameras.
Uh-huh.
And then it's a full 360, so the whole hospital room. So you
Okay.
can see what everyone's doing at the same time, and then we filmed on our GoPros so that we can put on top of it what your microscope is seeing, and then what the physician is doing. And then hopefully train our lovely students.
Wow! And what are you going to do with this? You're gonna do a project or something?
It's to have them find projects, to find things that they see that we can make better. How does it work here versus, say, the United States? So that brings me to my first question.
Yes.
How does it work here versus the United States? In terms of, it seems, Dr. Schmidt, that you've seen care at both places, and it seems to be very high quality care,
Yes.
but it's much more procedures. You're reaching a lot more people. So maybe you
Yes.
can talk a little about that.
Well, yes, this is a very interesting adventure here. People think that as we are here in Paraguay, which is a third world country, hidden in some corner of South America, that's full of Indians and Guaranis and all the 7 million people, that we are, maybe, with arrows, throwing arrows everywhere, and that's not the true story of what's happening here. In our case, this institution has already almost 30 years, and we have had a lot of contributors from everywhere, a lot of joint ventures with different enterprises, companies, and universities all over around the world. So, for instance, from Germany, Europe, different parts of Europe, the States, and we in terms of academic institutions, and also with different companies and big projects, all over around. I don't want to say names, but there is a lot of people involved in this story. Sometimes in a win-win situation, in different conditions, and that allowed us to be in a place where miracles, let's say, come true in terms of quality. Not only from the technical point of view, from the human resources point of view. So it's beautiful, it's nice. We do have here. Maybe right now we have 12 different clinics all over the country, and we provide 4 of them are with a high level of complexity of attention with surgery, and we are around 60 or more ophthalmologists or already ophthalmologists or residents of our information. And we provide in several fields of surgery and attention, 50% maybe or a little bit more, being conservative in cataract surgery, in retinal surgery around 70% of not only number, complexity of cases. So there are a lot of programs that we are running here in this institution that the government through the Ministry of Health doesn't provide to the people. So we help the official government institutions to reach some hidden corners all over around that they are not possible for them to reach. So in this frame of circumstances, so we do have here a high-tech institution with really good stuff. We have high-tech quality programs of surgery. We have surgeries, a 3D simulator to teach our residents, and we do have first line of technology to do surgery here. We have a lot of support from our friends and companies from starting US to Europe to all over around the world that is supporting every single day our work here. So people think that we are not able to do complex third-level surgeries, and this is not true. Maybe we 6 years ago or something like that, when there were only reported 40 cases of retinal autologous transplant, we did the case here number 41, and was the first case done in Latin America at that point. So and you see, these are not usual things to tell, and that happens in this situation. So we can afford those procedures, a lot of technology, a lot of not only surgery, also from the medical point of view, a lot of support for poor people, and there is a lot of projects right now that we're running projects here, and giving a massive impact in the eye care, health, or ophthalmology in this country. I don't know if you want me to tell you about several different things, but for instance, we teach the surgeons to do anterior segment and posterior segment together. So our surgeons, our modern surgeons, are perfectly trained to do complex procedures from an anterior segment part of the eye mixed with complex procedures or vitreoretinal surgery. So they're tremendously skilled, new generation.
Mm-hmm. So I notice your reach goes beyond Paraguay. So you're training a lot.
Yes.
We met someone this morning from Peru. There was another one from Colombia.
Yes.
How is that?
Well, there is a concourse every in October or something that we receive credentials and resumes from young medical doctors that want to be ophthalmologists. So we do the interviews and we invite the best of them to be part of our training program, 3 years training program, to make of them the biggest and goodest ophthalmologists in Latin America. So we have had residents from Mexico till Argentina, all over around. Central, North, Central, and South America. And usually what we have, it's half of our cohort is local, Paraguayan, and the other half is from other countries.
Oh wow. How many residents is it?
Right now we have 18 residents and 4 fellows.
Oh, quite a few.
Yep, 22.
And so they do full 3 years.
Residents, 3 years residency, yes, clinical and surgical formation. They do a lot of surgery in this period, and we have right now fellowship in retina, 2 years fellowship, glaucoma, and anterior segment surgery. That's what the programs that we are running right now.
Okay. I also noticed when we were touring, you have a lot of different clinics.
Yes.
So I thought a very interesting story was how you went from seeing in someone's eye during a consult, you can tell if they have diabetes. And so now you have a diabetes clinic, so you can just send them next door.
Yes.
How did that need come about? How did you?
Well, it all started. Yes, everything is mixed around. Yes, it all started with eye care attention, ophthalmic eye care attention, and when you start to see patients, see pathologists, so you can after that you get in touch with number one, the necessity of and all the problems that every patient has. It's not only ophthalmic problems. You see, we have a lot of kids, newborn and small kids with audition problems. They're deaf. So we started a program to help with hear aids and everything, to help those young, small people, kids that can hear. For instance, you see poor people that you see in their eyes and you see that they have no teeth. So you have to, or they have infections in the mouth. So you have to help them somehow. So we started an odontological program, to help them with the mouth and oral health.
Mm.
Same thing happened with us with the diabetical stuff. So you see here in Paraguay there is a lot of problem with diabetes. So statistics says that it's between 7 and 9%. It's much more than that. And you see young people and productive ages, you know, families, big families, a lot of kids living somewhere hidden in deep in the country, and in their 40s or in their 50s, and they should be very productive at the time and the economical support of their families. And they have diabetes since 20 years ago and they do nothing about it.
Mm.
So when they come here, you see mothers for families or young ladies or young men you know, blind because of the diabetes. So we decided not only do surgery, not only provide them with medication, we decided to start a diabetical program which is integrated by endocrinologists and medical internal medicine and pathologists to help them with the ulcers in the feet, with nutritionism, with everything. So we started a program to give them the support, not only from the ophthalmic point of view, from the all different points of view. Mm-hmm. So, and that is how it works, you know. As much you get in touch with the person, you find different things. You find that there is not only eye problems. There are a lot of problems hidden in every corner of their lives, and then we try to help them. And in some situations, we start programs with, for instance, sick people, and you then see they come. The family comes, and they have kids with autism, or kids with learning delay or something like that. So we started a program also to help kids with special needs. Mm. So this is the way how it works, and we have running, I don't know, maybe 5 to 6 programs we're running at the same time with the ophthalmic assistant. Mm-hmm. So for instance, I don't know if you have seen that we have here in this floor, we have, how do we say in English, albergue? I don't know. It's not. We have a small home here, maybe.
Oh yeah, it's like a hotel.
It's not. Yes, we don't have service. Yeah. It's not a hotel service.
But it has beds, like a hostel.
Hostel, correct. So when people come from different parts from the country, and they just have money to buy a bus ticket, they come here, and we have to do surgery or something like that, and they come with the Indians, with the whole family. So what do we do with them? We have to keep them here till we end their healing process, whatever it is, medication or surgery. So it's a different type of institution, you see? Mm-hmm. It takes my heart.
I know. Well, I think it's fantastic. Oh, yeah.
So you can just cut this part.
Oh, that's good. Oh, that's great. So I think you're really solving kind of everything, because you go and see a person, you really have that compassion, which a lot of doctors don't have.
Well, this is our purpose of life here. This is not a money question, you know. I'm not being paid by patient. Mm. We don't work with for our honoraries. Of course, we get a salary because we have to eat. We have families and everything. But we are people with a social sense of, a Christian and social sense of helping everybody. This is not about money. Where nobody's getting rich here. Mm-hmm. Well, in terms of money, we are all getting rich in terms of, helping people and God and everything. Mm-hmm. Something different.
Yeah, I noticed that too. That I think it was very helpful that your pay structure is way different than, say, what we call a fee-for-service as a type of pay structure in the United States. So you want to do more services because then you can charge more and more, whereas here everything is kind of negotiable depending on what the patient really needs. So what are they able to offer versus what they're not able to,
Absolutely
what you're
right.
able to help with versus
Absolutely
not.
right.
So I think that
Absolutely
was-
right. Absolutely right. There, if somebody needs attention and has no money, he's gonna get the same attention without any cost. That person that can pay something. It's and this is a very important thing that you said. We're not working for money. I get the same salary if I do one surgery or if I do 100 surgeries.
Mhm.
And in my case, I do 3 times a week, 20 cases.
Wow, that's a lot.
Thank you so much. I haven't cried that much to be irritated. No, it's fine.
Okay.
I'm so sorry about that.
Oh,
it's
it's
only
great.
one thing. I'm getting old, and this is I worked. I am originally from Venezuela. I was born in Venezuela, and I left my country I went to Florida, South Florida, in 2010. 40 years ago, I took my family, my wife and 4 kids over there. And before that, I have worked all over around Latin America. I worked for big companies. Well, I worked for myself. And in that part of my life, my conception of life was different. I was working as the American way, doing surgeries, getting money, being rich. That's what it was. I was a rich guy, very excellent surgeon. And I had everything in my hand in my young age and everything. So after that, for political reasons, we decided to live in freedom and democracy. So we left Venezuela and we went to the States, where I was working partially, and then I worked in Europe. I worked in Russia as a surgeon, in different parts of Europe and in Latin America before. And then once I was invited for Paraguay 20 years ago. Once I had an invitation of the Paraguayan Society of Ophthalmology. So I saw this country, and I decided, to try. Why don't we, instead of being in Europe or in Russia or whatever, I decided to try like here, and this is I'm working my pre-retirement, in terms of helping people and everything, and changing a little bit of things of life. So here things are done to help people. Of course, money is important, but it's important to keep the institution running.
So it's kind of figuring out how to balance those pockets.
And patients, we have patients, absolutely homeless patients that we keep and maintain and pay everything for them. And we have patients that can pay something, and with this income, we help to pay the bills of those patients that don't have the opportunity. That's how it is. So when you're in touch with people in need, become a lot of ideas, and you try to help them in every way possible. That's why they're running diabetes programs, special needs programs. Everything is running here. But of course, 98% of everything, it's all over around. It goes around ophthalmology, because the ophthalmology provides here to help and maintain, sustain the other programs.
Well, it's amazing how much you see just by looking into someone's eyes, right? Like how many problems you just observed by doing that. And that brings me so when you are long gone, where do you see for the future for ophthalmology, and for how do we figure out which need to solve for, because we can't solve all problems, but how do we solve which need first, and what need should we kind of start striving for so that we can make this better?
You mean in Paraguay?
Yeah. We'll worry about the United States later.
I don't know. I think that this institution has grown so much. We are overwhelmed. We are not talking about a little bit of everything. We have now 12 different points of attention around the country, and I had the feeling we grew up a lot of last years, and I got the sensation that we're not able to handle all this, growing. And God help us to provide human resources in every single point of attention, good quality human resources and technical prepared, so we can still providing the same standard of care that we're trying to provide some years ago. I don't know. I really hope that the institution has to keep growing and helping and I don't know. I would love to that the feelings and things we do were contagious all over around, so we can still growing. I don't know, and keep the most important thing is not only grow, to keep the standard of care, the standard of care of the products that we provide, which is healthcare, vision care, vision ophthalmology, eye care, which for the moment are international standards, absolutely first world international standards. As you saw yesterday, and maybe you will see tomorrow, our surgeries are first world class surgeries, and we still try to improve. Our physicians are traveling worldwide in different parts all over around, and congresses and everything, and we to keep us, in the front of the wave of circumstances in every field. So we travel, we send people to Europe, I'm a member of the American Academy of Ophthalmology. I'm traveling to Barcelona, Spain, into the European Congress of Retina in a couple of 3.5 months. So we travel, we bring stuff. Last week, part of our staff was in Mexico in a big meeting of public health, and we are leading. Paraguay it's a leader in the region in public eye care health. So we are right now we're running the third interviews, or the third big program of interviews all over the countries. So we will do 5,000 interviews in every single corner of this country, and to provide how is the visual health in this country. So it's called RAP. It's a rapid
assignment
blindness or something like that.
Oh,
So
rapid assessment of blindness.
Rapid assessment of blindness. Paraguay is the only country of Latin America that have had the 3 ones. This is the number 3. Paraguay is the only one that's running. We're running now the 3rd one, and all of these 3 assessments were did by Fundacion Vision.
So it's just
we
a
pick up the
large
data.
campaign of assessing and doing consults.
All over the country, and we pick up the data, and we provide all this data to the Ministry of Health. So in that terms, it doesn't matter here who does the work.
So I noticed it's grow with quality, right? So like even in your surgeries, they were very scalable, right? Doing a lot of surgeries, but with the best equipment, with the best stuff. And so I think growing with that quality is going to be the challenge.
Absolutely. And there is a lot of stuff. You have to train people, you have to select people, you have to train people, and you have to keep the quality, definitely. If we don't keep the quality, when you have such a massive type of attention, if you don't keep the quality of the attention, you can have a disaster in the future. So it's time, sometimes, I don't know, I'm not a specialist in that, I am just a poor guy. I do surgery. I have no studies in terms of, I have no knowledge and studies in terms of other stuff, but people around me helps me a lot in terms of statistics and everything, and human relations and all this, which is not my.
So I'm really understanding epidemiology, right? So the background, the history, the prevalence, really understanding what the real needs are.
Absolutely. You know, I breathe surgery, I eat surgery, and I sleep. I sleep surgery. That's what I do. That's my real strength. I would say so. But there is a lot of people around that takes care of all what it's make the surgery sustainable, you know. And I'm sure it has to be a point somewhere where we have to stop growing and you know, to keep the quality of things. You know, it's not only, you know, just grow and grow without keeping.
I think the same comes to technology, where it's not constant new. Because I noticed every time you get something new, it doesn't work.
I'm afraid of technology. You know, you buy one phone or you buy one camera, and you are still paying in code because the phone to AT&T or whatever company you're doing, you buy the phone, and when you're paying the 5th, the 6th month of whatever you bought, or GoPro, whatever. So then you have the new model. You have learned how your phone works, and you have 3 new models going.
So imagine all the physicians having to learn the new interface over and over and over again, which I think with the FACO machines was a major concern. Is now they have to upgrade. How are you going to retrain everyone? And then if so,
there is a big new step coming. Hopefully this year we will be able to share and acquire a 3D surgery. We're gonna hopefully acquire, this is a microscope that you don't see through the objectives. Mm-hmm. So you put your special glasses on and you can do 3D surgery just watching a TV. Just watching.
So it's using that so you watch like all around you? Or you don't need to look down in the microscope? You don't need to.
I think it's a binocular surgery system.
Okay.
It's a 3D binocular surgery system when you work with 2 cameras, one which with every single eye, and you can see 3D images where you can move and do microsurgery, the one you saw yesterday, mm-hmm. but without direct vision to the patient. So you can watch the monitor. You have a camera inside the eye. You watch the monitor, and you can do with good depth perception do surgery, mm-hmm. cataract or retina surgery without the direct vision of the patient. So this is the next step, and hopefully, I guess if it's not this year, we're getting this technology next year.
What problems will that solve?
What problem?
Yeah, what problems? What major problems? Why did you want to use sort of now a new 360 view? I can imagine sciatica might be one.
Yes. One of the problems is that the surgeons complain about the position when you do 10, 12-hour surgery. You have the position when you sit and you work, you know, it has some of the surgeons complain of you know, neck problems and everything. That number one. Number two, the quality of the image for academic purposes. So it's not the same thing, the image you get through small cameras as you saw yesterday. Mm-hmm. Maybe it could be 4K or whatever, but you don't have that quality of image and 3D images. And for academic purposes, you can do surgery, and your residents or your fellows can see the surgery in 3D, and you can explain maneuvers, teach surgery much better when you're working in a 3D environment. Mm-hmm. So this is a big step in other words. There are solving some problems with the delay time in terms of how you move your hands and how you see mm-hmm. what is the delay time of your movements and what you see in the screen. Yes, but we are, hopefully we will be in the edge of the technology in that sense in the short future. And the same thing that we're working right now, and it's very important, we are trying to get two big steps in technology to diagnose and treat diabetic retinopathy. Number one, there's a high definition, small pupil stereo images that without dilating the pupil of the patients through a pupil of 2 or 3 millimeters, with the special cameras you can have 130 degrees angle retina images with only 2 pictures, with no madratic cameras, high definition cameras, so you can in a couple of seconds, less than a minute, with just two photos, you can have a very wide angle picture of the retina, and you can work with in distance. So you can have somebody in the field taking pictures, sending the pictures in the web or in the cloud, and somebody in other space just reading the images and having artificial intelligence in the interpretation, or people doing interpretation. Then you can save resources when you're going to know what patient needs to come to for treatment, and what patient can stay there. So
new form of telemedicine.
New form of telemedicine through artificial intelligence.
Yeah. So we get a lot of this in AI, is having the doctor at least kind of guide the machine learning process, because in computer vision world, garbage in is garbage out. If you don't know what to look for,
exactly,
it's going to misdiagnose or represent features or certain parts of, say, your retina. So it would be kind of a vision like that, where you get the images, AI is kind of asking, and you're giving it input so it can get better.
Yes, but we have a lot of institution that collaborates with us, we're right now working with them in this previous phase, and there are a lot of images. Those systems of AI are collecting thousands of images monthly and perfecting the diagnosis, and we are on it. So this is one step. The cameras we are receiving hopefully in a couple of weeks. Portable tomographers, so we can do retinal tomography in the field.
So it's all battery powered.
Battery powered tomographers. They're on the way, right?
Are they small?
They're
that was
small.
Another thing I get a lot of complaints of is.
No, they're really small.
So
we're getting cameras, we're getting all this equipment, and with the 3D surgery and small pupil cameras, we will be in the edge of the technology. We will be there.
Okay.
And that's going to happen now.
That's happening now, yeah. And so I know in the future, because they have these small phaco machines, but they're super pricey, everyone just says, I just want it to last 10 years. And I just want to have it, easy to see with the way it used to always be. So are a lot of technologies, especially when you go out into the field, is that still like the big need? It's kind of make it last, make it portable?
Yes. Well, yes, we have, phaco machines are always useful, and we have a lot of them, big phaco machines. We don't have a lot of portable machines, but we do have some, inventory where we can move them and do surgery. We provide around 1,500 surgeries out of our regular ORs every year. So we do, all the surgeries we do, 1,500 were outside our OR, all over around. So we talk with hospitals or the Ministry of Health or different places. We take our equipment there, microscopes and phaco machines, and we do surgeries out of the.
There's a lot of transporting.
A lot of stuff moving all over around. We have, I don't know if you saw it, we have a small bus which is with a clinic inside. So we travel also around. There's a lot of things happening every single day here in Fundacion Vision.
It's just to wrap up, do you have advice for our young engineers and our medical students? If you were a medical student, what would you tell them besides run?
Yeah, I have a lot of ideas that you can do. We have to meet. This is a beautiful profession what you have, and you are the right hand. All of this in your field, you are the right hand of all the ophthalmologists of the medical professional. Medical doctor, medical surgeon does nothing without all the research and development and invention that you do, guys. So I have seen so many things, so many ideas, so many brilliant, great ideas coming out from medical doctors. Don't think that wrong idea that a medical doctor or ophthalmologist has to be in the leading every project, everything. That's not the way it is. If you're getting in touch and familiarized with what we're doing, you can have, and you have, in the biomedicals area, the ideas that we are not able to see because we are not in touch with the lead of the technology. So, valving system for glaucomas, monitoring pressures, a lot of stuff as we were talking yesterday. Who knows about chemical laser stuff? Regular people, without the support of this part of biomedical engineering and all this part support, definitely we would be in the Stone Age in medicine. That's what I think.
Thank you. All right.
Absolutely. There's a lot of, if you don't, you have the ideas, you think, and not only this, if you don't have the idea, and we have the idea, you make the idea come through, the reality, That's it. I have a lot of ideas to tell you.
Oh, please.
You can make money. If you do the equipment, you can make a lot of money with this equipment. There are a lot of stuff to be done in our field. And in practical terms,
Yeah.
to help people and devices, a lot of stuff.
Mm-hmm.
So
Yeah. If you have ideas, let us know.
We will.
We will make them for you.
Yeah.
We'll mail them back.
You will help people and make money for sure.
All right. Well, thank you so much.
No, my pleasure.
Thank you.
Thank you.
And this is